The broadcast is now starting. All attendees are in listen-only mode.
Welcome to IFN Live, a Q&A session with Dr. Kara Fitzgerald, who many of you know from her excellent module in IFN Track 3 on Advanced Functional Medicine Labs and Methylation. Dr. Fitzgerald received her doctorate of naturopathic medicine from National College of Natural Medicine in Portland, Oregon. She is recognized as a thought leader in functional medicine, has published in numerous peer-reviewed journals, and is a contributing author to many functional medicine textbooks. Dr. Fitzgerald is the lead author and editor of the highly acclaimed Case Studies in Integrative and Functional Medicine and lead author of Methylation Diet and Lifestyle. I also want to give a swift shout out to Dr. Fitzgerald's podcast, which personally I think is the best in the functional medicine podcast space. You do not want to miss it. I look forward to it every time you produce one. So you can read Dr. Fitzgerald's complete bio on our website or on her website, drkfeducation.com, as you see there, or just, of course, drkarafitzgerald.com. One detail before we get started, you can go ahead and type your questions for Dr. Fitzgerald in the control panel. So without further delay, welcome, Dr. Fitzgerald. We're really excited to have you with us here today. And the first question that has come in, if you only had one functional test to order on a patient whose major complaint is fatigue, what would it be and why?
Wow. Well, first of all, thanks for having me. It's really fun to come and do live Q&As. And it's always lovely to connect with both of you. And I'm so glad that your program is just rocking it. I love it. Yeah. Okay, so so all I know about this, now let me just say, in the real world, clearly in the functional medicine model, we would not prescribe anything if our history was so woeful as to only know the individual has fatigue. So let me just put that out there, because a big part of what I'm going to talk about today, I'll just give you the answers in advance to this quiz, is the importance of utilizing the full functional approach. And lapping the matrix again and again as need be, as Dr. Tom Salt says, until we really figure out what we need to do for our patients. However, that said, actually, I would pop quiz this. I think I want to turn this back on to the listeners, but I'm only going to give you a nanosecond because I'm going to keep talking. So I'm just going to, if somebody presents to you with fatigue, if you have a client coming to you with fatigue and you're thinking about the matrix, what might you light upon? What matrix node might you light upon? That would inform my testing. So the place that you pop fatigue into the matrix will inform. Now, obviously, we can put fatigue into probably every node, but likely the first place for me is going to be energy. In the I'm going to be thinking about mitochondrial function, and to that end, I think we're going to get the most bang for our buck. Now, remember, we only know fatigue, because I know some of you are thinking adrenal function, right? Some of you are thinking thyroid. But if we want to drill down a little bit further and arguably address those things and more, I would be thinking about mitochondria, and I would be thinking about, not just an organic acid assessment, but maybe something even bigger, like an ion or a nutrieval. So I would have organic acids, I'd have a little snapshot into amino acids, I'd have some toxins, and we'd have some markers of gut activity and so forth. So I think that would cast the widest net, yield the best results as far as a specialty test, and give us all our central energy pathways in the organic acids. So we'd see the Krebs cycle intermediates, we'd see how fats were being used. we'd see, we'd have some information around protein and amino acid behavior.
Beautiful. Wonderful. Thank you. All right. Here's the next question. There's a couple of parts to this question, Dr. Fitzgerald. It's about the organic acids test. The question is basically saying that, they understand that an organic acids test has its advantages, and one of the advantages is that we're really not measuring vitamins in the blood, but we're looking at functional biomarkers of their activity. And so I guess the question is that why is that okay for some vitamins, but then when it comes to something like vitamin D, we look at vitamin D in the blood?
Well, you know what? I think, that's a great question. I would say that, what would I say about it? Surrogate markers, I want to pop this question. You can at least think about these questions I'm going to throw at you, even if you don't put answers into the chat box. So we know surrogate markers of a vitamin's activity is incredibly useful, like methylmalonic acid. There's an accumulation of it if there's insufficient B12. So we get an intracellular piece of information from looking at methylmalonic acid. So with vitamin D, what would our most obvious surrogate marker be? It might be, off the top of my head, it might be something challenging to assess like bone health, right? Or we might be looking at what's going on immunologically, and the influence of D is really pretty profoundly far-reaching. We might look at parathyroid hormone, but the literature on D is solid using a direct assessment. So I would say two things. One, we can see strong D associations, actually usually D deficiency and disease associations, by looking at D directly. So it's been established in the literature as direct measurement being the best. And then secondarily, I would say trying to find surrogate markers of, useful, easy surrogate markers of D activity is much more challenging than, say, looking at B12 or folate activity. Does that make sense?
Yes. Excellent. Thank you. Okay, the next question is there a lab test that is used for histamine intolerance?
Yeah, there are. It's really pretty difficult. So your best bet for assessing histamine intolerance, so your best bet for assessing whether somebody is anywhere on any of the manifestations of excess histamine, and there can be many. It can be immunological. It can come from allergies, or it can come from just mast cell activation for a myriad other reasons, not necessarily mediated by allergies. It can come from intolerance, as the question suggests, which is non-immunological. So is there an increase, is the microbiome imbalanced towards, an inability to break down histamine? Is there some damage to the gut wall, and therefore diamine oxidase is being produced insufficiently? There's so histamine, I guess one of the things you just want to think about is, how do you think it's either being overproduced or under metabolized? Like you do want to kind of flesh that piece out. And then that'll help you. What will it help you do though? Really probably your best bet for measuring is going to be doing a good histamine elimination diet. And I know folks in the program are well suited to do that, or doing something like having them take an antihistamine. Even a pharmaceutical antihistamine is fine as a diagnostic. Do they respond? Do their symptoms clear up? That's going to help you. So beyond that, there are things that we can look at. In the urine, probably the best marker is N-methylhistamine. What else? In blood, we can look directly at histamine. There's some argument that whole blood histamine might be more reliable. Tryptase is another marker that can suggest mastocytosis if it's elevated, or if it's just what we might call high normal. It can suggest, it can suggest mast cell activation that's not quite, mastocytosis. So it's pretty challenging, in short. Like, people need to generally be symptomatic, and so if you're ordering those kinds of tests, if you can, I know I'm not sure if folks here are ordering routinely, Quest and LabCorp tests. You want to advise your patient to actually get some of these completed when they're symptomatic, which might mean giving them a few lab slips, and they can, run over there. I mean, it's pretty cumbersome to make a good diagnosis. I have seen high histamine on occasion. I've seen high normal and frankly elevated tryptase, but way less frequently than I actually assess. And even N-methylhistamine, which is arguably the most sensitive when looking for mast cell activation, is pretty hard. We can measure diamine oxidase. I think Dunwoody is the main lab. There may be something through Cyrex. You'll have to look. I haven't done it. Do they have antibody? Do they have diamine oxidase antibodies?
Dunwoody does.
Dunwoody. Okay. Okay. So Dunwoody is the place to go. Yeah. So there's a smattering of assessments out there that we can do, but arguably your clinical judgment and the looking at trialing somebody on an antihistamine or a low histamine diet is going to be more effective. I do want to draw your attention. Thanks for the shout out on my podcast, Kathy. I so appreciate your support. Thank you. I did podcast with Dr. Theo.
Yes.
I'm not gonna do service to his name. I'm so embarrassed, but it's Dr. Theo Herides, I think.
Right.
I just called him Dr. Theo because I was not doing a good service on articulating his name. But he is unequivocally the premier scientist looking at all things histamine, all things mast cell, all things mast cell activation. I mean, he has more publications. He was the guy who actually characterized cromolyn back in the 70s. I mean, he has been in the best universities researching this. He's got just forever. I mean, he is the person to talk to. In fact, actually, while he was characterizing cromolyn, which is one of the early, gastrocrom, one of the early sort of mast cell stabilizers, pharmaceuticals, he was also looking at flavonoids, and he was the one who put luteolin on the map way back in the day. And there's an interesting backstory to that whole journey for him. But we talk about labs in my conversation, and he outlines what he thinks is best, and you'll hear what he recommends, which is basically what I've outlined. But you can go to the podcast show notes page and actually pull up the transcription. A lot of people have done it. That podcast was very dense, and just having the written section on labs, so you can reference it, I think is pretty useful.
Yeah, and also I think, Kara, Dr. Lawrence Afrin is another one who's done quite a bit of research in that arena, and the product that I think it's Dr. Theo, one of the ones that he came up with is Neural Protect, right, with a K on the end. Neural Protect, which has, as you mentioned, the luteolin in it, correct?
Yes.
Okay.
Yes. Yes. He and I actually dialogued about PEA, phosphoethanolamide, palmitoyl phosphoethanolamide, and he is not a big fan of it. However, I think there's a place for it. There's a lot of research on it, PEA, as a mast cell stabilizer. Okay. So it's an intervention that I've used in my practice, but I know he and I kind of debated it a little bit, or he didn't think it was as efficacious.
Okay. Well,
and let me just tell you this, hot off the presses. So we have a clinic immersion program I know you're aware of, and these are, our clinic immersion is where clinicians transitioning into functional medicine shadow with us in our rounds meetings, and we have Q&A, and we have a bunch of live offerings, but they actually get to experience us in the trenches practicing functional medicine. And so this morning in clinic rounds, one of our nutrition residents actually was talking about hormone influences on gastrointestinal, so sex hormone influences on gastroneuropathies or IBS, et cetera. And one of the things that she pointed out, which was pretty exciting for all of us, was progesterone as an antihistamine. In it actually inhibiting mast cell degranulation, progesterone. So something to consider, just going when we're working with women, balancing hormones, dropping estrogen dominance or correcting estrogen dominance if that's the case, maybe even prescribing progesterone for folks that we think have a histamine imbalance or a mast cell activation picture or allergic disease. We know mast cell activation plays a role in interstitial cystitis. Anyway, something to think about that was a pearl for me this morning from one of our nutrition residents. Yeah, really interesting.
Beautiful.
Wonderful. Thank you.
Sheila.
Yes. Okay, so this next question kind of has two parts that I think kind of two parts, but the question is asking you about what your protocols are, Dr. Fitzgerald, for both Epstein-Barr virus and H. pylori. So,
okay.
Anything you want to share about that?
Yeah, absolutely. So H. pylori, I use, we're mentioning brands. I know we are. We've already mentioned brands, so there's no issue. So Diagnostic Solutions Laboratory, I think they've done a really good job in their GI map test at including the numerous virulence factors that may be present when H. pylori is identified. And in fact, to circle back to my podcast again, I had a good conversation with Tony Hoffman, who is the CEO at Diagnostic Solutions, and that's on the podcast. And Tony and I go back forever because we both worked at Metametrics Laboratory back in the day. So it was nice to connect with him, and his background is in stool testing, and I think they've launched a really amazing product with DSL. And so he and I have an extensive conversation on H. pylori and what to do about it. His thinking is that if you identify H. pylori on a stool test, that you need to eradicate it, that even if it's not a problem player at that measurement, that it can become. And thus, as far as he's concerned, just go in there and eliminate it. There are some suggestions, though, that and I brought this up to him, and he didn't think they were strong, but there are some suggestions that the presence of H. pylori without virulence factors might be commensal. It actually might be a little bit protective. There are some studies out on looking at kids with allergic disease and a reduced incidence when there's some H. pylori present. I tend to be a little bit more conservative, I think, than Tony. If H. pylori is present and there are no classic H. pylori symptoms present, then I might not be particularly worried about it, quite frankly. If there's no sense, if there's no upper GI pain, if they're not complaining of ulcer type symptoms, gastrointestinal GERD, if GERD's not, or heartburn, if those are not present, I may be less concerned about it. Depending on what the rest of the panel looks like, I might be addressing sort of a benign or not alarming kind of dysbiosis picture. However, if I do see the virulence factors present, or if there's a high quantity of H. pylori, I think we can do a really good job with natural interventions. I don't think that we have to jump on triple or quadruple therapy these days, unless somebody's really sick, in which case we do want to. So what kind of interventions are we going to use? There are some really fabulous combination products that include mastic gum, bismuth, and I would be starting off something, something of that nature with the patient. So there's mucilaginous herbs to just kind of protect the stomach, and then there's some antimicrobial herbs. So both protect, soothe. DGL is another really big one that will help. Maybe slippery elm, marshmallow, etc. Those things can kind of soothe that area. Zinc carnosine can help rebuild, and then just some gentle antimicrobials.
Okay. Excellent. Thank you. Really quick, I think you mentioned a podcast. What podcast did you just reference earlier?
So this was again on New Frontier. So this was my podcast where I had a conversation with Tony Hoffman.
Gotcha. Great.
And he and I have a really pretty lengthy discussion on H. pylori, identifying H. pylori and what to do about it. He is in favor of full eradication. I think it's a little bit more nuanced.
Kathy, you want to take the next question?
Sure. Yeah, lots of questions on lab testing. Not surprising. The next one is, what labs do you use for advanced lipid profiling?
In our practice right now, we kind of use all of them, you guys. If a person, we can get really good advanced lipid panels these days, both insurance covered and at a number of different places. So Quest is a big go-to for us because they just recently purchased Cleveland Heart Labs, so you can get this full suite of Cleveland Heart tests plus the advanced lipid panels that they were offering back in the day. Actually, they've kind of just folded. So they had the whole Cardio IQ suite, and then they brought in Cleveland Heart. If you're into TMAO, for instance, you can grab that now pretty easily. You can get really good omega-3 and 6 panels through Quest now, amazingly enough. I mean, you can get a comprehensive look at, lipids and beyond through Quest now. LabCorp has a more limited but similarly robust panel. What else can you get? I mean, you can get myeloperoxidase, LP(a), you can get the plaque test, et cetera, and I think through both labs, but Quest is more robust these days. And then the other lab that we use quite a bit is Boston Heart. We get really good coverage with Boston Heart, and we have, each of us here in the practice have our own rec sheets made up. So my baseline Boston Heart panel is more involved than Dr. Litwin's, and then so I'll order mine instead. But we have individualized recs based on what we want. You can get the genetics through Boston Heart, and they're usually covered by insurance. So the challenge with Boston Heart, though, is that we don't do in-office phlebotomy. So you need to have we do have a mobile phlebotomist who will swing by and do blood draws for us, or go to the patient's home, and there are some local providers who will do draws for us. So that's what we're doing.
Right.
Kind of whatever works, understanding that we do have good access to advanced lipid panel assessments these days. It's pretty nice. Like, there's no reason for us to go, unless we're doing a follow-up, very pointed follow-up on, did we get HDL up? Did we get triglycerides down? I don't think there's any reason to do a standard cholesterol panel these days.
Right. Okay, excellent. So here's our next question. So now if you're not testing, are there issues with, she says, everyone being on methylated folate and vitamin B12, and what levels are safe if you're not testing? That's what she's.
Can you just restate that for me?
Yes. So the question is, in this situation, I guess she's framing it as, if you're not testing, are there issues with essentially putting everybody on methylfolate and methylated B12? And if so, what level would you consider safe?
Okay. All right, so before I jump in, I just want you to be thinking about what kind of physical exam findings might you see if you're thinking about B12 status, folate, other B vitamins.
Mm-hmm.
So just kind of ponder those. I do think we need to be mindful. I mean, I'm not sure who, if the individual who posed this question is aware of the methylation diet and lifestyle study we just completed. So here's my opener.
Tell us more.
So back in the day, I was actually talking to you guys about this a long time ago, but when I first dove into looking at the literature on epigenetics, the body of the science was focused on cancer, so epigenetics in cancer. Epimutations outpace genetic mutations, gene mutations, 10 to 1 or more. So changes to gene expression via augmenting epigenetic activity is a much bigger driver in cancer. And one of the areas where we really see aberrant epigenetic activity is in DNA methylation. So there are a methyl group will be placed on a cytosine when a cytosine is proximal to guanine on DNA. So a CpG site can be methylated, and when it's methylated, it's inhibited. So in cancer, one of the common mechanisms, and there are many mechanisms, there are many aberrant epigenetic changes, but a methyl group can be placed, or multiple methyl groups on these cytosines in tumor suppressor genes. So for instance, think a BRCA gene. We know a mutated BRCA gene, is going to likely result in cancer at some point in time. So if your patient has a BRCA1 or BRCA2 mutation, chances are they're riddled with hormone-sensitive cancers in their family, and they're thinking about, prophylactic hysterectomies and mastectomies and so forth with that mutation, because the likelihood is so high. Turns out we can actually hypermethylate the BRCA protein and inhibit it from its tumor suppressor role. In fact, when you look at many tumor suppressor genes, you can see that they can be hypermethylated and inhibited, and the cancer microenvironment will hijack methylation activity to promote tumorigenesis. And so that was the first literature that I began to really dive into back in the day, and I was stopped in my tracks because I prescribed high-dose B12 and folate, methylated or otherwise. There's a host of different B12 and folate types.
High dose meaning high dose.
So high dose would be, anywhere from maybe 1 milligram of folate up to, 5, 10, 20, depending.
Right.
Just kind of depending on what I was seeing, and did I identify need? Did I think clinical picture correlated with a need for high dose? Now, let me actually just say that I still think there's a place for B12 and folate supplementation. I haven't completely eradicated it from my practice at all. And I think there's a time and a place for higher dose supplementation, but I have endpoints in mind. And that's because I've got to ask myself, could providing these vitamins actually promote abnormal methylation in the epigenome? Could I actually be promoting cancer, and so on and so forth? So when I read that literature, my nutrition director, Romilly Hodges, and I began to sort of brainstorm on upstream ways we might approach methylation, and that's how we came up with the diet and lifestyle program. And then we were given a grant, an unrestricted grant, to hire Health Gut Institute at my alma mater, NUNM in Portland, to conduct a study, actually seeing whether we altered epigenetic expression. We're done with the study now, and we're writing up, actually just before I hopped on this call, I was working on our paper. We're writing up for publication now, and I will say that we did, using a diet and lifestyle program, see changes to epigenetic expression. And I'm not going to go into detail now because we really need to publish first. But we were pretty excited to see that we were making a difference in the way that we were thinking we might.
That's wonderful. And it's going to be interesting once your publication is released to see how you all went about measuring that. I guess what I'm thinking about is
I can tell you all about that. That's not confidential.
Well,
but yeah, go ahead and make your comments, and then you can just ask me. If I can't say something, I'll just tell you I have to wait till publication, but I can go into a lot of details with you as you're interested.
Sure.
But go ahead and make your comments, Sheila.
My comment was that it seems like it would almost be near impossible to flesh out whether or not you promoted cancer in a person, because there's just so many different factors in what can be cancer causing. I mean, so how could you know that? How could you know, oh yeah, well, that was we were the ones who caused that? How could you even begin to really know that? And the other thing is, I'm thinking about something like a basic multivitamin with 800 micrograms of methylfolate. I mean, should I really be concerned about that?
Yeah, that's right. That's right. I know. It's important that I want us to be a little bit mindful. So on one hand, I want us to be aware of the fact that our interventions can be potent. But I also want us to be, there are very modest dosages that we can use that are likely pretty safe.
Yeah.
So how would you actually know? Right now, so we looked at the methylome. We literally used what it's called the epic array from Illumina, and it's for research purposes only. We measured 850,000 CpG sites. So we measured a lot. There's actually about 4 million. Yeah, we did. So we were looking very carefully, baseline, midway, and follow-up to see how our program impacted DNA methylation specifically. There will come a time when these tools will be available to us as clinicians, and we'll have a more sensitive understanding. There's a smattering of There's a company called Zemo, and they've got a direct-to-consumer test called My DNAge, and there is a DNA methylation clock that is a more rigorous measurement of biological age than, say, telomere length. So, are you aging rapidly, or is your intervention actually turning back the hands of time? And that is something that consumers can buy. There's a clinician, clinician only test called IVGene. IVGene looks at 2 genes and measures methylation burden, and those 2 genes are associated with a handful of different cancers, and that's by IVGene. It used to be called Unko Blot, that lab, but I think they've changed their name, and I'm just drawing a blank on it right now. So there's some limited tools available, but without question, more will be available, and we'll see, what our interventions are doing. We know, for instance, from looking at, large epidemiological databases, that synthetic folic acid alters immune response. High serum folic acid has been associated with increased risk for certain cancers like colorectal cancer, breast cancer. We in our world say, okay, that's just because it's synthetic. It's folic acid, and we don't activate it in the same way, and it's got, the potential to be nefarious and, with different mechanisms. And I think that's fair, but I also think we don't know that for sure. We're just kind of telling ourselves that. I mean, I've told myself that for years when I was back in the lab in Metametrics, and we started measuring methylfolate and so forth. We thought, we really poo-pooed synthetic folate. So I do think using bioidentical forms is better. But I think our supplements impact epigenetic expression. There's no doubt about it. So there's some, we might just want to have an endpoint in mind. If somebody comes to me, as many people do, with polyneuropathy, or something that I think is clearly attributed to various B vitamins like B12 most commonly, insufficiency, I'm going to go after that pretty aggressively, to turn around what's going on as far as the neuropathy is concerned. But, you know, at some point, I think it's reasonable to drop the dose down to the lowest possible and to rely on diet, and lifestyle.
Mm-hmm. Really, really great words of clinical wisdom that I think we all need to embrace. So thank you, and thank you for that update on really an exciting project that we can't wait to hear more about. Wow.
Yeah, it's pretty exciting. We did a webinar. So I fleshed out all of this, and then I went through the study details, what we did, what we measured, et cetera, on a methylation diet and lifestyle webinar through our website. And I know we're going to be sending out a link to that. There's going to be a way for people to access that webinar. There's no charge associated with that, and it's a drill down. It's for, you know, professionals. So I don't know if Karen and Lara just maybe put in the chat how people can access that. I frankly am not entirely sure. That's terrible, but
that would be great.
Be able to. Make sure you're on our newsletter, I would say. Make sure you're at least on the professional newsletter so that you can get pinged on it. Okay, what else do we have?
I love the get pinged. Okay, here's one for you, Dr. Fitzgerald. When working with children under 5 years old, what gut health products protocols do you like? And then there's a little bit more to this. Symptoms: gassy, slimy stool, occasional diarrhea, some incontinence. The GI map completed, and with minor elevated good bacteria markers, elevated bacillus under opportunistic bacteria, and they're taking Claire Labs Therabiotics regularly. And this person mentions that they have a hard time deciding what is a reasonable dosing for this age with regard to, you know, products like L-glutamine, zinc, aspulardi, herbs, etc. So there's a lot there. Unpack it as you might.
Sure. Is there any behavioral? Are there behavioral issues with this GI picture in this child? I mean, is this
not mentioned, but maybe is your not mentioned in the question, but they may be able to write in the chat box or the question again if there are.
Okay, it just sounds like almost like a typical gut you see in kids on the autistic spectrum. So that just kind of made me curious, and I might be a little bit more aggressive. Maybe not at baseline, maybe not at starting, but eventually, if we are working with sort of a gut-brain axis case. I guess my first question would be, it sounds like
right in, excuse me, sorry to interrupt, no behavior issues thus far.
Okay, good, fabulous. Okay, good. Okay. So first of all, I would suggest that you look at diet, and I know it's really hard to do in kids and peds, and see what kind of just ensure that they're on, that you've ruled out any hypersensitivities, any allergies, that the fiber is balanced, that they're getting some prebiotic foods. And I know it's a journey with kids as far as that goes, but it's the heaviest lifter. As all of us know here, diet is going to be the most impactful on changing around the microbiome. And it's going to be not only the most impactful, but really the fastest way to go is going to be through diet. So take a careful look at that and make sure that you've got it as dialed in as possible. I would think about, I suppose the safe way to start supplementation in kids, if they're, healthy and not really super sensitive, is just to think about body mass. And, if you look at the dosage on a bottle on an adult product, and you think it's a 150-pound individual, and your child is maybe 50 pounds, so you want to just dose in thirds. That's a very modest starting point, and I generally in practice will go higher than that, and in some cases I'll go to an adult level intervention. I would not stay with any one probiotic long term. I would rotate around. BioGaia is a great. They have a great formula for babies. What is it called, you guys? The BioGaia product. It's baby BioGaia. I don't know what it is, but anyway, it's BioGaia, and it's just a really easy liquid. It's a drop dose. You can increase it, but it's just well tolerated, and I get good outcome with it. With rapid transit, that's not due to some kind of an infectious gastroenteropathy. I'm almost always using Saccharomyces boulardii. Well tolerated by kids. Fluorostore in a powder form, easy to, and it tastes decent. It's easy to administer. Antimicrobials, I use Biocidin in my peds all the time. It's easy. It's liquid. You know, my daughter is 22 months and she does not mind a squirt of Biocidin in her mouth at all. So that's pretty impressive. It does seem well tolerated, and she does a squirt. You can just drop dose it. You can put it in a teaspoon of water and then maybe give a half or a quarter teaspoon to start and see how kids tolerate it. What else? Kirkman Labs. Kirkman started working primarily with kids on the autistic spectrum. And so their products are formulated. They have more adult products now, but they've got a nice selection of, you know, well-disguised powders and chewables and so forth for kids. I think Orthomolecular has done a good job. My daughter's probiotic right now is the Springboard chewable, and she says, she can't say probiotic, but she could say like addict. So she has all day long. She always always wants her probiotic, like the first thing in the morning. She goes and holds on to the fridge. Addict. So she loves those. She loves the Springboard from Orthomolecular. I want to kind of take a picture of her and send it to him. I think it's really funny. So those guys, I think those guys have done Springboard through Orthomolecular. They've done a good job on kids' product design. And if you're thinking about enzymes, and this is for adults as well, but Houston Enzymes, just a really, really great resource for enzymes of all kinds, but especially the ones that we're thinking about with kids and kids on the spectrum, like breaking down oxalates and phenols and so on and so forth. The other one I want to say too that's really potent, and again, pretty well tolerated, is Alimed, and that's the, so there's Alimax, which is a type of Alimed. There's Alimax Pro, which is the same as Alimed, just under it. I don't know why they branded it differently, but you can get these as liquid. They're stable alicillin. Stabilized alicillin. I think it has the best research on them, and you can drop dose them because they're liquid. So you can start low and just titrate up as needed.
Excellent. Well, speaking of antimicrobials, here's a question. Are you concerned that using antimicrobials like Biocidin or even things like colloidal silver, that in a sense they're weak antibiotics and they might contribute to antibiotic resistance?
No, I'm not actually. So that's that. I think because the cool thing about using Biocidin is that it's a combination and it's using whole plants. And so I think that there are nourishing, so there are antimicrobial elements within it, but there are also gut nourishing elements. Mm-hmm. And so I'm really not worried about it. And then if we look at single constituents, like say berberine, in whatever form, golden seal or Oregon grapefruit or however you're getting it, or just a isolated berberine constituent, there's no data. There are no data on it. I know, so again, back when I was at the lab, which is going on, over a decade since I was there, but we were doing a drill down into looking for this, and we've continued to pay attention to the body of evidence, and it's scant. if non-existent. Essential oils, you guys, again, don't forget about essential oils. Talk about really potent antimicrobials. I mean, we think about oregano oil all the time, but you know, all of those guys, rosemary, thyme, etc., potent antimicrobials. And I think when we use them in the context of a whole plant,
right,
which you're not necessarily doing with an essential oil, but I think you're on safe grounds. Yeah, and if you are using something that's isolated and you want to be conservative, you know, rotate it. Rotate it out.
I didn't hear you speak to colloidal silver. Do you have an opinion about that? The use of colloidal silver? I've seen some really amazing results with colloidal silver and EBV. Didn't know if you had any thoughts about that.
Yeah, I think colloidal silver is great, and it's easy to administer because it's flavorless. I have colloidal silver at home, and I've you know, taken it myself, and I use it with my daughter. Gotcha. So yeah, I think it's a nice player in the arsenal.
All right.
Okay, great. Getting back to the B12 story, and here's a question. When a patient has symptoms of a B12 deficiency, what do you recommend if the patient has a B12 level greater than 1200, but the methylmalonic acid is normal? And then the second part of the question was, does NAC help the body absorb B12 supplements? So,
all right. So if somebody has a normal methylmalonic acid and their serum B12 is high, right, but you think clinically they're presenting with B12 deficiency, your laboratory data are arguing against your clinical interpretation in that case. They've got to find, now, if you did a blood methylmalonic acid, if you got a methylmalonic acid from, say, Quest or LabCorp, they actually have horrible reference ranges. They're only going to flag a positive when it's 3 standard deviations out. So that means that only 0.01% of the time are you going to see a positive MMA. So a normal blood or serum MMA from a standard lab like Quest or LabCorp is pretty useless because of the reference ranges. And I don't believe they've changed them. I think everything is still set at 3 standard deviations. Therefore, if you're getting a normal MMA on, say, an organic acid from any of the labs that run them, any of the specialty labs, then you're looking at a saner reference limit, like 2 standard deviations, and sometimes they even show you the 1 standard deviation. So that's way more sensitive. If it's normal on that lab, then that's solid. So if you've got high serum B12, you've got a normal MMA, you really may have effectively ruled out B12 as the cause of the patient's symptoms, and you need to look elsewhere.
Yep.
Next, as far as absorbing B12, I'm not sure. You know, I'm not sure.
Okay. Thank you.
Yeah, we've got a few questions here. I think we kind of hit this, but I just want to make sure, going back to the H. pylori, this might be a little redundant. What is the recommendation for the length of time to treat H. pylori with antimicrobials and gut healing? What is the recommendation? Let me read this again. What is the recommendation for the length of time to treat H. pylori with antimicrobials and gut healing protocol?
Yeah, good question. I would be doing, if you're going with botanicals, we have to go longer. I would be doing, you know, at least 8 weeks. And and if they've got the virulence factor, if you used a DSL, then if they're symptomatic, I might even go longer, and I might rotate them through, you know, so start them on, I don't know, like Gastromend HP, I think, is a really fabulously designed product from Designs for Health, and maybe rotate them over to some other, you know, like maybe an alicillin or colloidal silver. I mean, I would have to kind of think about it, but you might rotate through a few times before you retest, and pay attention. You know, if you're going after it relatively aggressively, that's because they're symptomatic. So you know, just check in with them on how they're doing, and that'll help guide your time to retest.
Wonderful, thank you.
I wondered if a SIBO question was going to be surfacing. Or SIFO. What kind of dietary and supplement recommendations do you have for Candida yeast overgrowth when there may be SIBO as well?
You know, my nutrition team is on, and I feel like they just need to talk about it. I just send them there. Actually, aren't I talking to a bunch of nutritionists here? Okay. I think so. SIFO and SIBO, I guess, you know, what have they done? Have they done it? So I'm actually speaking.
Will you just mention what SIFO in case there are some listeners if they're not familiar with that?
Yeah, it's fungal, so small intestinal fungal overgrowth, and I think it's well, I think in functional medicine we recognize it, we consider it within the context of, you know, causes of, you know, the symptom picture of SIBO could be SIFO, and then of course the bacteria can be, you know, hydrogen sulfide producers, hydrogen or methane, and so, you know, we do need to kind of tease things out, and our dietary intervention is going to reflect what we're suspecting. You're not going to pick up hydrogen sulfide on a breath test. You're not going to identify fungal overgrowth on a breath test. If you do an organic acids, you might see a high diarabinitol on a organic acids through Genova. They're the only lab that has that diarabinitol, and it's pretty useful. Clinical history might suggest fungal overgrowth. I mean, have they been on immunosuppressants, history of steroids, history of yeast infections, you know, any of the typical kind of yeast pictures. Are you seeing anything in the stool test? Although arguably identifying fungal overgrowth using stool is, you know, isn't the best tool. I prefer diarabinitol in urine. Sometimes we look at Candida antibodies in blood. But clinical picture is really useful there. So diet is going to be, you know, and it's a case-by-case basis. So we do prescribe FODMAP a lot, but if we're suspecting SIFO, we're going to be going low carb, and we're going to be really mindful around anything that's going to stimulate fungal overgrowth, which is basically sugar. I'm not worried about mushrooms and vinegar. I mean, I think that's a little bit old school at this point. And my experimentation with the more classic anti-Candida diet is that, you know, omitting those things really didn't make a difference by and large. So low carb, FODMAP diet. I may suggest that we pull out any hypersensitivities or, you know, or certainly allergies. What else? Sometimes in our patients who are really, really suffering quite a bit and need an aggressive baseline intervention, we'll do an elemental diet. We might do a really low calorie, extremely hypoallergenic diet, like maybe some chicken and, I don't know, what do we use, you guys, commonly? You know, chicken and perhaps a smidge of greens, or, you know, something that's going to be well tolerated but very simple. And we might do that for a few days just to see if we can give them some relief. And then we'll expand the diet based on how they're feeling, and just because most people can't handle such a limited rotation for long, we want to have it to be more nutritious. So I wish I could give you a hard and fast protocol, but it really is case by case.
Right. Absolutely.
Case by case. Yes.
Yeah.
Well,
and then if Clara and Karen are on the call, so they might have some thoughts that hopefully they can pop in the chat.
Excellent. Well, thank you, Dr. Fitzgerald. And wow, it looks like we've actually got to all of our questions. That's awesome.
Okay.
And yeah, and I wanted to let everybody know again, Dr. Fitzgerald's website, Dr. Fitzgerald, either drkarafitzgerald.com or drkfeducation.com. Is that right?
Well, so drkfeducation.com is the website for the training programs that we offer to professionals. So if anybody,
Right.
if there's a clinician who's interested in joining our clinic immersion program and kind of tracking with us in real time in our functional medicine clinic, you can access information on that there. And also we have a functional nutrition residency program, and
Excellent.
that information is housed there. Podcasts, blogs, you know, all of our recipes, all sorts of stuff on the methylation diet and lifestyle. That's at drkarafitzgerald.com.
Excellent, excellent. Thank you for letting us know. So I hope everyone has enjoyed that as much as we have. That was fantastic. Great practical clinical pearls, really wonderful. A couple of things I want to make sure I mention, and that is that, yes, we are always recording all of our programs, the webinars, and so this presentation, this Q&A discussion link will be sent to you as long as you registered for it. So we're gonna make sure you get that. We are not offering CEUs for this particular hour, so just want to make sure you're aware of that. However, we do want to let you know about a couple of goodies. We do have a wonderful 6-part laboratory mini-series coming up that's going to be available to you free of charge in Track 2. And that will be coming soon in mid-January. We'll have more details to share with you as that as we get closer. So when you register for Track 2, you'll see the information and the various topics that are going to be covered there. So be sure to check that out. And on that note, we are offering our Gift of Gratitude holiday special of a 20% discount to either Track 2 or Track 4 or both if you'd like. So be sure to take advantage of that special. The coupon codes have been sent to you. The deadline for that special is Tuesday, the 31st of December. So be sure to take advantage of that. And I think with that, Kathy, I think we're all set.
Yes.
So we thank you, and Dr. Fitzgerald, thank you again for your wonderful expertise, for your generosity and your time and your support. We're huge fans.
Likewise, you guys. I'm really big fans of yours too. And you know, in this conversation, I'm just thinking we need to collaborate more. We need to have our Venn diagrams interact a little more.
I like that. Yeah, absolutely.
It's so fun. It's so fun to hang out with you two. And
well, thank you. Yeah, no, there's I think a lot of wonderful overlap and collaboration and room for sharing, and so we're really grateful for your time today, and we thank you, everybody. We'll see you next time.